Hey, good morning and welcome to UroNurse. I'm your host, Vic Sinise, and welcome to the show. We meet every Saturday at 9 a.m. Central Time, and we come to you from all of these places at the same time. So welcome, no matter how you're watching us live, this is how we get to you. This is your first time checking us out, be sure to check out our website at uronurse.com. Best place to learn more about the show. Also, the best place to go to catch all of our past episodes. Yes, we have 126 of those. And if you want to listen to us in your car, no problemo. Check out our UroNurse Plus area, which will bring you to all of our favorite podcasting apps where you can go ahead and check us out on an audio podcast. This week, we have a special presentation. This is going to be another one of our contact hours. It's good for a half a credit, 1.5 hours worth of credit. It's on urinary tract antibiotic review, drug review. It's kind of a nice little review. Since I'm on the road broadcasting at this point, I thought this would be a nice one to bring in here. And we're going to do that for you right now.
Hi everybody, my name is Clover. I am the current infectious disease pharmacist at Northern Healthcare, and today I just want to talk about the urinary tract antibiotic drug review. So this is my disclosure. I personally do not have any financial interest with the manufacturers of the products that I will talk about in this presentation. The objective for today's, by the end of this presentation, you should be able to describe the mechanism of action and resistance, spectrum of activity, and the basic pharmacokinetic profile, as well as the adverse drug event of the antibiotic that we commonly use for urinary tract infection, such as like nitrofurantoin, fosfomycin, trimethoprim, sulfamethoxazole, and aminoglycoside. You should also be able to define the clinical utilities of these antibiotics in the urinary tract infection and other common indications. So because many of the antibiotics that we'll talk about today mainly used for urinary tract infection, I just want to set the stage and review the common uropathogens that you will come across when you treat the patient for urinary tract infection. These bacteria have an acronym called KIPS. So what does KIPS stand for? It stands for Klebsiella, E. coli, Enterococcus faecalis, or Enterobacter cloacae, Pseudomonas or Proteus mirabilis, Staphylococcus saprophyticus or Serratia. Among those, E. coli would be the most common causative organism. This slide just shows you an overview of mechanism of actions for different types of antibiotics. And for today's presentation, we will mostly focus on two drug class. One of them is trimethoprim sulfamethoxazole, and the other one is aminoglycoside. So let's go ahead and focus on the trimethoprim sulfamethoxazole first. So trimethoprim sulfamethoxazole, or sometimes you will hear people refer to this medication as trim-sulfa. The brand name of this medication is Bactrim, or also called Septra. It's abbreviated as TMP or SMX. So TMP stands for trimethoprim and XMX stands for sulfamethoxazole. It's a two different drugs, but in the same pill. Sulfamethoxazole specifically belongs to a group called sulfonamide, and it's structurally very similar to a natural molecule called para-aminobenzoic acid. And why is that important? We will talk in just a few seconds when we talk about the mechanism of action. Trim-sulfa available is a combination formula in a ratio of 1:5. And when we're talking about the dose of trimethoprim sulfamethoxazole, we always talk about the dose of trimethoprim component. And we automatically assume sulfamethoxazole going to be 5 times more than the trimethoprim. Trim-sulfa is available in both oral and IV form. In the oral form specifically, they will commonly referred to either single strain or double strain. So for single strain means that trimethoprim are 80 milligrams and double strain means that trimethoprim is 160 milligrams. So how does trim-sulfa work? As I mentioned earlier, sulfamethoxazole is structurally related to a natural molecule called para-amino benzoic acid, and this molecule is what is needed to initiate a folic acid synthesis pathway. And because sulfamethoxazole looks very similar to this molecule, it will kind of trick the bacterial enzyme to bind to sulfamethoxazole instead, and because of that, the folic acid synthesis cannot continue. Trimethoprim will similarly to sulfamethoxazole, but a little bit different because it will bind into a different enzyme within the folic acid synthesis pathway, and the end result of that is that they will inhibit the folic acid synthesis in the bacterial cell, and because of that, the bacteria cannot grow. So Bacteria, however, is very smart, right? If we can have a medication to inhibit their growth, they will find a way to overcome that and develop resistance. There are a few different ways that bacteria can be resistant to trim sulfur. One of the ways is that to produce a lot of para-amino benzoic acid, and when they have a lot of para-amino benzoic acid molecule, then sulfamethoxazole will be less likely to bind into the bacterial enzyme, and because of that, we cannot shut down the folic acid synthesis pathway. Another way that they can develop resistance is that just to have a different enzyme that have very low affinity to sulfamethoxazole, or they can just have a way to prevent sulfamethoxazole to get into the cells to begin with. And another way they can develop resistance is that they just develop a completely different pathway for folic acid synthesis. So what is the spectrum of activity for trim sulfur? Trim sulfur actually can cover both gram-positive and gram-negative organisms, but for gram-positive cocci specifically, I want to point out that trim sulfur is a good option for Staphylococcus. However, the activity against Streptococcus is variable and sometimes unreliable. One other thing is that trim sulfur do not have activity against Enterococcus species, and it's important to know because Enterococcus species is one of the common uropathogens that can cause urinary tract infection. For gram-negative bacilli, trim sulfur in vitro have activity against Enterobacterialis organism, for example, like E. coli, Klebsiella, and things like that. However, because of the overuse of trim sulfur, some of these isolates develop resistance to trim sulfur. Trim sulfur do not have activity against Pseudomonas, and it's important to remember it because Pseudomonas is one of the common organisms that can cause healthcare-associated infection. Another organism that can also cause healthcare-associated infection is Stenotrophomonas. And Stenotrophomonas is a multi-drug-resistant organism. It's intrinsically resistant to a lot of common antibiotics that we use. However, trim sulfur is considered to be the drug of choice for Stenotrophomonas. Other common pathogens that you will come across is pneumocystis jirovecii or PJB or Toxoplasma gondii. So those pathogens that can cause opportunistic infections in HIV patients. Trim sulfur is considered to be the drug of choice or first-line alternative for this organism. Trim sulfur do not have activity against anaerobes or atypical. So what can we use trim sulfur for? So trim sulfur can have a lot of indication that we can use for, and that including like urinary tract infection, both cystitis and pyelonephritis. Other infections that I have mentioned, for example, like Stenotrophomonas infection or BCPS pneumonia. So now take a step back and learn more about trim sulfur pharmacology. So as I mentioned earlier, trim sulfur is available in both IV and oral form, but trim sulfur have an excellent bioavailability. We mean that if your patient have a functioning GI tract, the oral bioavailability of Trim-Sulfa is above 90%. So it means that we should transition from IV to PL as soon as possible. Trim-Sulfa is also very well distributed to various tissue. It can bind to plasma albumin. And one of the things that I want you to remember is that Trim-Sulfa can cross the placenta, which means that we have to be very careful if your patient is pregnant and you want to initiate the patient on Trim-Sulfa. Trim-Sulfa also inhibit one of the enzymes called CYP2C9, and that can cause a lot of drug-drug interaction that I will talk about in just a few seconds. So what is the adverse effect profile of Trim-Sulfa? So Trim-Sulfa can cause a skin reaction as mild as just a skin rash or photosensitivity. One of a good counseling point that whenever you initiate the patient on Trim-Sulfa, you should ask the patient to wear the sunscreen as well when they come to in contact with the sun. Other adverse side effect of Trim-Sulfa, for example, like bone marrow suppression, like thrombocytopenia or leukopenia. Trim-Sulfa can also cause hyperkalemia or pseudo-elevation in serum creatinine. And I want to talk a little bit more about this because a lot of clinicians are hesitated to use Trim-Sulfa because they are worried that their patient will develop AKI. However, remember that Trim-Sulfa can cause a falsely elevated serum creatinine because they just inhibit the secretion of creatinine. So just because somebody initiated on a Trim-Sulfa and have a bump in serum creatinine doesn't mean the patient have AKI. We have to look at the patient as a whole. For example, we need to evaluate if the patient have reduced urine output and things like that. One of the things that Trim-Sulfa can cause is that they can precipitate in the urine and cause obstruction. So whenever you initiate the patient on Trim-Sulfa, you want to counsel the patient to drink a lot of water. Trim-Sulfa, as I mentioned briefly earlier, that they can bind into the albumin. And it is important to know because in a newborn, a very young baby, what it do is that it will display the bilirubin from the albumin and cause increased level of bilirubin and cause a disease called connectivitis. And because of that, we have to be very careful when we want to initiate Trim-Sulfa in the patient who pregnant. The recommendation is that generally we want to avoid it during the first and the third trimester. Trim-Sulfa can have drug-drug interaction with warfarin. And why is that? It's because, as I also mentioned a couple minutes ago, it can inhibit warfarin metabolism by inhibit the enzyme CYP2C9. It can also display warfarin from albumin. And because of that, if the patient already on warfarin and you initiate the patient on Trim-Sulfa, it can cause the warfarin level in the patient increase significantly. Whenever that happens, whenever the patient is on warfarin and you start the patient on Trim-Sulfa, you have to make sure that you monitor the iron off very closely just to make sure that we don't overdose the patient. So that is a lot of information about Trim-Sulfa. I just want you to make sure that we summarize them. Some of the things that I want you to know walking away from this presentation related to Trim-Sulfa is that Trim-Sulfa work by inhibit the folic acid synthesis. It have no activity against Pseudomonas. It can have a variable activity against gram-negative organism. It can cause pseudo-elevation in serum creatinine. And it is a drug of choice for Stenotrophomonas and BJB. With that, let's move on to the next drug class, which is aminoglycoside. So there's a lot of aminoglycoside that is were on the market. With the first one was go out to the market in 1949, and the most recent one is come out to the market is plazomicin in 2018. But the only 5 aminoglycosides that I want you to be familiar with tobramycin, amikacin, neomycin, gentamicin, and streptomycin. So basically, I want you to think of the acronym TANKS. How does aminoglycoside work? Aminoglycoside work by inhibit protein synthesis. So similar to human being, bacteria need protein to survive. If a medication inhibit their protein synthesis, then they can no longer function in an efficient way. One of the things I want to point out is that in order for aminoglycoside to work, they require oxygen. And because of that, if the bacteria is an anaerobic organism, then they are intrinsically resistant to aminoglycoside because, again, aminoglycoside cannot work without oxygen. There's multiple different ways a bacteria can develop resistance to aminoglycoside. For example, they can have an enzyme to break down the medication, or they can just have a way to prevent aminoglycoside to get into the bacterial itself to begin with. What is the spectrum of activities for aminoglycoside? So when we think of aminoglycoside, we think it's mostly aerobic gram-negative organism. For example, Enterobacterales, Pseudomonas, Acinetobacter. But sometimes you will see that aminoglycoside can be used in a combination regimen for the synergistic effect for gram-positive organism. For example, like Staph, Phyllococcus, Streptococcus, Enterococcus. Again, aminoglycoside do not have activity against anaerobe. Where do you see the use of aminoglycoside? So aminoglycoside can be used for a lot of indications, but most of them will be in a combination regimen. The only 2 indications that you probably see aminoglycoside be used monotherapy is when the patient undergo GI surgery and we want to have an intestinal decontamination for the patient, then we give the patient a dose of oral neomycin. Another indication that you might see aminoglycoside be used monotherapy is urinary tract infection. And what is so special about aminoglycoside for urinary tract infection, specifically for cystitis? Let's hold on to that thought and we will talk about it in just a few minutes. So before we talk why aminoglycoside is so special in the urinary tract infection, let's talk about the pharmacology of aminoglycoside. So aminoglycoside is very water soluble and it's excreted unchanged in the urine up to 85 to 95%. So what does it mean? It means that if you give the patient just 1 dose of aminoglycoside, then the concentration in the urine can remain therapeutic for several days. And because of that, if your patient just have uncomplicated cystitis, you can give the patient 1 dose of aminoglycoside and the patient is considered to be complete therapy instead of have to discharge the patient on 3 to 5 days of antibiotic. So for other indication, you will have asked like, how do we dose aminoglycoside then and how do we monitor for that? So remember that aminoglycoside is considered to be a concentration dependent bactericidal activity. What it means is that the efficacy of aminoglycoside depends on the peak concentration. We want to achieve a high peak concentration for aminoglycoside. Historically, when we dose aminoglycoside for gram-negative infection, we previously give the patient a small dose of aminoglycoside and give it every 8 hours, so 3 times a day. And what does it do is that we realize that it will achieve only a lower peak concentration and a higher trough concentration. But then the higher the trough concentration means the patient is more likely to experience side effects. So that is not the most optimal way to dose the patient, right? So more recently, we shift away from the traditional dosing every 8 hours to extended interval dosing, which means that we give the patient a very high dose of aminoglycoside but less frequently. And what we hope to achieve is that we hope to achieve a high peak concentration to optimize the efficacy and lower drop concentration to minimize the adverse drug event. For synergy dosing for gram-positive infection, then we still do the every 8 hours based on the current data that we have. Similar to vancomycin, aminoglycoside dosing is individualized and a little bit different from facility to facility. So make sure that you check with your hospital or institute protocol when you need to dose an aminoglycoside for the patient. Sometimes the clinician are hesitated to use aminoglycoside due to adverse reaction. So you would ask, like, what type of adverse drug reaction that we should think of when we think of aminoglycoside? And then that would be neuromuscular blockade, nephrotoxicity, and ototoxicity. The nephrotoxicity incident would be depending whether or not the patient already have risk factor for nephrotoxicity as well. So some of the take-home point that I want you to work away from this presentation with aminoglycoside, including that aminoglycoside is active against aerobic gram-negative. It's mainly bactericidal. It's worked by inhibiting protein synthesis. It can cause neuromuscular blockade, can cause nephrotoxicity, and can cause ototoxicity. Don't forget that the one-time dose of aminoglycosides for uncomplicated cystitis is a great option so that we can prevent the patient have to go to the pharmacy or exposure to other broad-spectrum antibiotic. With that, let's move on to our next agent for today, nitrofurantoin. So nitrofurantoin have a brand name of Macrobet. It was first introduced in 1952. How does nitrofurantoin work? It works by creating a free radical and damage the bacterial DNA. And the bacterial develop resistance by creating, obviously, the gene mutation to stop the nitrofuran activity. Another way that it can develop resistance is to have the efflux pump. So when the nitrofurantoin is in the bacterial itself, the efflux pump will just pump the nitrofurantoin right back out. The spectrum of activity for nitrofurantoins that I want to point out is that nitrofurantoin have in vitro activity against the most common community-associated uropathogens. For example, like Enterococcus species, Staphylococcus saprophyticus, E. coli, Klebsiella, and things like that. It does not have pseudomonas activity, however. So nitrofurantoin have a very good bioavailability, like around 80 to 90%. It can achieve a very high concentration in the urine, but low concentration in the kidney and low concentration in the prostate tissue. And because of that, it is only recommended to use nitrofurantoin for acute cystitis, but not pyelonephritis or prostatitis. One of the things I also want to point out is that the nitrofurantoin excretion is decreased if the patient have renal failure. So the cutoff is around creatinine clearance less than 30. Nitrofurantoin is generally very well tolerated, with the most common side effect was just gastrointestinal intolerance. Some of the take-home points for nitrofurantoin, including like it is active against more common uropathogen, it is bactericidal because it damages the DNA, it's used for cystitis, and then you shouldn't use it for pyelonephritis, prostatitis, and creatinine clearance less than 30. The last agent for today is fosfomycin. Fosfomycin is discovered in 1969. And it works by inhibit cell wall synthesis. So what does it mean? It means that your bacterial cell usually have a cell wall. It acts as a protective layer for the bacteria. What fosfomycin do is that it just inhibit the building up of the cell wall and make the bacteria very vulnerable, and then it will die. Phosphomycin have activity against most common uropathogens, including like Enterococcus, E. coli, Klebsiella, and even Pseudomonas. But one of the things that you need to be cautioned is that if you use phosphomycin for anything other than E. coli in terms of gram-negative coverage, sometimes this organism can have a false aging, and it can cause the patient to fail on therapy. Phosphomycin is only available as an oral option in the U.S. And then if you are from the outside of the U.S., then sometimes you will see that phosphomycin is available as an IV therapy. Phosphomycin achieve very high concentration in the urine, and because of that, it is a good option for urinary tract infection. Generally, it is very well tolerated medication. These are the dose that you can use for uncomplicated and complicated cystitis. One of the things that you need to be cautioned is when using phosphomycin for pyelonephritis, because the concentration in the kidney tissue is not as high compared to the urine concentration. So the take-home point for phosphomycin, I want you to think the acronym FOCUS. What does it mean? It means that phosphomycin is only orally available in the U.S. It should be used for cystitis because it achieves high concentration in the urine, and it works by inhibit the synthesis of cell wall or peptidoglycans. So that is a lot of information that I go over today. Some of the take-home point for the urinary tract antibiotic review that I want you to remember from this presentation. Nitrofurantoin and phosphomycin should only be used for cystitis. Trimsulfa can be used for both cystitis and pyelonephritis. Trimsulfa is the drug of choice for steno, Trophomonas, and BJB. Aminoglycoside can be used monotherapy for urinary tract infection, and for other infections, it should be used in a combination regimen. And with that, before I let you go and get excited that now that you already master about antibiotic used for urinary tract infection, it's just a reminder is before you prescribe any of these antimicrobials, just take a few seconds to ask yourself whether or not my patient needs antibiotic. Does my patient even have symptoms for infection? Because some bacteria grow in culture doesn't mean the patient have infection. If the patient have symptom free, then we should just let it be. And that is all I have. Thank you so much for listening to my presentation.
Well, I hope you enjoyed that show. Again, go to our website and you'll be able to click on the button to get to your CNEs or CMEs or whatever you're getting. Just click that button. It'll bring you over to the website where you'll have to kind of forward through a few things to get to the point where you can take the test. You'll take a pre-test, then a post-test, and then you'll get your certificate. Super easy to do. So just go ahead and do that. And hey, join us next week. We're going to be back home in our studio. Can't wait to be doing it from my studio again. We've got a great show coming up for you. And here's a little excerpt on that.
Ellatone. Ditch the pads, stop your leaks, and feel the freedom in just 6 weeks is a revolutionary solution for women struggling with stress urinary incontinence. Presented by Gloria Kolb, County founder and CEO of Ellatone, offers an innovative, non-invasive device designed to strengthen pelvic floor muscles and improve bladder control. Unlike traditional methods like surgery or daily reliance on pads, Ellatone uses gentle electrical stimulation to mimic Kegel exercises, targeting the root cause of leaks. With just 20 minutes a day, users can see noticeable improvements in as little as 6 weeks, regaining their confidence and freedom to live without worry. Learn more on UroNurse.com.
So there you have it. Check us out next week to learn more. We'll be back and have our expert panelists with us to hopefully answer any other questions that you might have. See you again live from the studio.